Functional mitral regurgitation or secondary MR represents a complex interplay where the mitral valve is a physiologic bystander to underlying left ventricular or atrial pathology. Unlike primary MR, the leaflets and chordae are typically morphologically normal. The regurgitation arises from geometric changes that prevent proper coaptation. Functional mitral regurgitation is most commonly classified using the Carpentier system as type 3B restricted motion during systole or type 1 annular dilatation. Ventricular functional MR, left ventricular remodeling, often from ischemic heart disease or dilated cardiomyopathy, leads to papillary muscle displacement. This results in apical and lateral tethering of the leaflets, increased tending height and tending area. Atrial functional MR, increasingly recognized in patients with chronic atrial fibrillation. Massive annular dilatation and impaired annular dynamics prevent the leaflets from meeting even in the absence of significant left ventricular dysfunction. One of the most debated aspects of functional MR was the threshold for severity. The discrepancy between guidelines historically centered on the effective regurgitant orifice area. One set generally utilizes a threshold of more than or equal to 0.4 square centimeter for severe mitral regurgitation harmonized with primary MR. Other set previously utilized more than or equal to 0.2 square centimeter as severe, arguing that lower volumes carry higher prognostic risk in heart failure patients. Proportionate versus disproportionate functional MR. The Greben-Packer model helps explain why some patients respond to transcatheter intervention while others do not. Proportionate functional MR. The degree of MR is expected for the degree of LV dilatation. These patients rarely benefit from edge-to-edge repair, that is TEER, as the primary problem is the ventricle. Disproportionate functional MR. The MR is excessive relative to the LV end-diastolic volume. These patients, similar to the COAP trial population, show significant mortality benefits from TEER. Management strategy. Guideline-directed medical therapy. The cornerstone. ACE inhibitor, ARB, ARNI, beta blockers, MRA, and SGLT2 inhibitors can promote reverse remodeling and reduce functional MR. CRT. In patients with LBBB and wide QRS complex, cardiac resynchronization therapy can improve papillary muscle coordination and reduce MR acutely. TEER, like MitraClip, indicated for symptomatic patients on optimal GDMT with disproportionate MR. Effective regurgitant orifice area more than or equal to 0.3 square centimeter and LV end-diastolic volume less than 70 ml per meter squared. Surgery, generally reserved for patients undergoing CABG or AVR. Isolated mitral surgery for functional MR, undersized annuloplasty or replacement, has high recurrence rate and no proven survival benefit over medical therapy alone. When evaluating for potential intervention, specific geometric measurements are critical. Tending height, the distance between the mitral annular plane and the coaptation point. A tending height more than 10 mm is a technical indicator of severe restriction and is associated with a high risk of annuloplasty failure. Tending area, the area enclosed by the leaflets and the annular plane in the apical four-chamber view. A tending area more than 2.5 square centimeter suggests significant leaflet tethering. Posterior leaflet angle, the angle between the posterior leaflet and the annular plane. A posterior leaflet angle more than 45 degrees is a strong predictor of recurrent MR after surgical ring annuloplasty.